Hi, I'm Dr. Ken Charlin. Welcome to another episode of Brain Bites, where I can share with you a little bit of information about how neurology works, something about a condition you're interested in, maybe learn something, up your game, have a strategy that you can use now or in the future. I want to talk today a little bit about the subject of neuropathy. That's Neuropathy, neuropathy. And neuropathy is a very common problem. I'm going to give you a definition of neuropathy, but I also want to offer some thoughts about how this word is misused. First of all, neuropathy simply means disease or condition affecting peripheral nerves. These are the nerves that send sensation from your skin surface, actually from your muscles and tendons about the amount of length and tension on a muscle. Basically, they're sending information to your central nervous system, meaning the spinal cord and brain, or they are receiving information from the central nervous system, generally going to muscles to exert power or to make adjustments in the length and tension on a muscle so that, for example, you can stand up without simply falling over. So very important, neuropathy is not a symptom. Neuropathy is pathology. It's disease of a peripheral nerve or group of nerves. I have a lot of folks come to me saying they have neuropathy, and what they really mean is they have loss of sensation or numbness, or they have tingling or creepy crawly feelings on their skin or pins and needles. And this definitely can be due to peripheral neuropathy, but I always say that the nervous system is really a big geography, a broad geography, and before we decided that the problem is due to a peripheral nerve, a neurologist has to take a careful history and physical and determine where within this geography that is the nervous system the problem is coming from. So numbness, tingling, pins and needles, creepy crawly sensations, for example, could come from the brain. They could come from the spinal cord. They could come from nerve root compression as those nerve roots are entering or exiting the spinal cord. So peripheral neuropathy. Peripheral neuropathy can affect a single nerve. It can affect a group of nerves in sort of a random distribution, one here, one here, one here, so forth. We call that multiplex neuropathy. And then there's the term polyneuropathy, which is generally a symmetric neuropathy, meaning typically it's going to affect the longest nerves. So those are the feet, the nerves that are the furthest away from the central nervous system. And often as it affects the feet and goes up the leg, we refer to this neuropathy as having a stocking-like or sock-like distribution. So generally symmetric, right compared to left, similar, and going up from the toes and the foot up to the ankle, the lower leg, and even further up as the neuropathy worsens. And as that happens, very often the hands are also affected. And so we'll talk about a glove-like distribution in the hands. So different types of neuropathies. Mononeuropathy, a classic example would be carpal tunnel syndrome, where the entrapment is with the median nerve. It involves the median nerve in the wrist or the ulnar nerve in the elbow, your funny bone. Multiplex neuropathy or mononeuritis multiplex, where that neuropathy is a number of nerves, but not necessarily symmetric. Maybe it's in a hand, but then in a foot, etc. That can be due to an infectious cause or what we call vasculitis, where there's inflammation of blood vessels that are nourishing the nerves, for example. And then there's the most common thing besides the mononeuropathies like carpal tunnel and ulnar neuropathy or ulnar entrapment, which are the polyneuropathies. And that's very common because diabetes is such a huge problem around the world, including certainly in the United States, and many people with diabetes do suffer from neuropathy. I've said that the investigation of neuropathy starts with a proper history. neurological history and neurological physical examination. From that, the neurologist determines if the problem truly is a peripheral nerve problem. Very often, the person might have loss of temperature sensation or vibratory sensation in their feet, where we use a tuning fork that's vibrating. We put it on, for example, a last bone on the finger, and if the person can't feel the vibrating tuning fork or can't feel it for the full duration of the vibration until it would normally stop, then they've lost some sensation. It could be also evaluated through loss of position sense, where the neurologist says, close your eyes or look away, and they're going to bend the little finger or a toe on the foot up or down in a very subtle fashion, as a patient would be able to say, my toe's going up, my toe's going down. If you can't feel that, then you've lost what we call proprioception. Sometimes we use a sharp object. We have to be very careful with that. We might break a wooden Q-tip that's clean, has not touched anyone else, so it creates a slightly sharp edge, but not enough of one to break the skin or really hurt. But the idea is, can you feel the pointier end of a broken Q-tip compared to, say, the cotton tip end, which is going to be soft, and the neurologist will say, is this sharp, is this dull? And if you've lost the ability to discriminate sharp versus dull, that can be a sign of neuropathy. And then we might be looking for those changes in that stocking glove distribution. So we take the Q-tip sharp end and we go up the leg until the person says, I'm starting to feel it, or down the leg from the knee. Maybe they say, I feel it, I feel it, I feel it. I'm not feeling it as much anymore. And they lose that sensation as we go down the leg. These types of physical findings suggest a peripheral neuropathy, and then the neurologist may order blood work to investigate some specific causes of neuropathy. They probably will schedule you for what's called a nerve conduction test, EMG, and I have a whole separate video on nerve conduction testing and EMG. Ultimately, the test will confirm the diagnosis of neuropathy. It may also lend some information to what the cause of the neuropathy might be. If we think about a peripheral nerve, we might think about just a standard wire, and I'm going to borrow a wire from my headphone here. This wire has a rubber coating on the outside which insulates the metal on the inside, and nerves have kind of a fatty coating over them called myelin, which actually enhances electrical conduction along the nerve, so makes it conduct its signal faster, but it also insulates the long arm of the nerve called the axon. And when we do a nerve conduction study with electromyography, we can often determine whether the primary problem is loss of this myelin coating, so we would say it's a demyelinating neuropathy, or whether the long arm of the nerve called the axon has been damaged, in which case we call it an axonal neuropathy. Depending on the pattern of the neuropathy, that may provide more information to determine the cause of the neuropathy. I've already talked about diabetes as being a major cause of neuropathy. Another common one would be kidney failure, but we really want to look across the board. So sometimes neuropathies can be due to trauma. They can be due to genetic things that you're essentially born with. There's a classic one called Charcot-Marie-Tooth disease. You can have inflammation of blood vessels causing neuropathy. We call that vasculitis. You can have other metabolic or hormonal causes of neuropathy, such as low thyroid or hypothyroidism. You could have B12 deficiency. Vitamin B12 is a nutrient where we frequently do see low levels contributing to neuropathy. And you can have autoimmune causes where your immune system is attacking your peripheral nerves. And we see this sometimes in the emergency room and in the hospital acutely with a classic ascending weakness type of disorder, meaning starting in the legs and going up the legs, causing tremendous weakness, called Guillain-Barré syndrome, also called acute inflammatory demyelinating polyneuropathy. And this is more common in the winter seasons, flu season, etc. Can occasionally be triggered by things like flu vaccines as well. There's a variant of this that's a more chronic, insidious onset neuropathy called CIDP. There's other types of neuropathies that have autoimmune components where they're treated with various approaches that suppress that immune response. And of course, there are functional medicine strategies to address an overactive immune system. Occasionally, underlying or hidden cancers can be associated with neuropathy, and there are situations where we need to test for that. Sometimes a cancer announces itself as a problem with the nervous system, such as a peripheral neuropathy, and then we kind of work backwards and discover this person has an underlying cancer. The most common thing that we would see in the clinic is related to a cancer called multiple myeloma, and we do a blood test called a serum protein electrophoresis, where we're actually checking for an immune globulin that your immune cells are producing over and over and over and over again. So it's called a monoclonal gammopathy or monoclonal expansion of an immune globulin. This may be due to a bone marrow cancer called multiple myeloma. So I hope this has been helpful. It's brief. Obviously, we could go into much more detail, but I wanted to start off just to review with this idea that neuropathy may be characterized by numbness, but when a person says they have neuropathy, unless we actually know that their neuropathy is due to a problem with their peripheral nerves, it may not be neuropathy. You can have numbness from other causes or other locations within the nervous system, such as the spinal cord or the brain or a compressed nerve root. And then there are different types of neuropathies. One nerve, multiple nerves in an asymmetric fashion, or a symmetric ascending stocking glove polyneuropathy. Then neuropathies affect both the axon or the long arm of the nerve, or they affect the conductive coating around the nerve, slowing that signal. Finally, the neuropathy condition can have many causes, from acquired and traumatic to related to metabolism and hormones and nutrient deficiencies to other inflammatory causes such as vasculitis, or in some cases even underlying cancer that can be genetic, etc. There are many causes that we need to investigate in the neurology clinic. Then many neuropathies do have conventional treatments that can address that neuropathy, but a functional medicine approach such as our brain tune-up program can also be integrated into the overall treatment plan, and in some cases used as the only treatment plan, because most of us don't want to have to take medications. We want to address the root causes. If you have any other questions, I'd be happy to answer them. You can certainly put them in the comment section below, and I get notified when someone has left a question or a comment. Also, reach out to us at functionalmedicine.doctor and schedule your free 15-minute consultation today. It's been a pleasure to visit with you. I'm Dr. Ken Charlin, Charlin Health and Neurology, Ozark, Missouri, Chief Medical Officer, owner, and developer of the Brain Tune-Up.